Wow, what an act to follow. Well, thank you for the invitation, and Srini, thank you and the organizing committee for giving me a few minutes of your time to talk about endovascular fistula creation. No disclosures. The outline, I'm going to review some of the pertinent anatomy that is relevant to this area. I'll discuss the two devices that are currently available for this procedure and quickly kind of run through some of the outcomes and some considerations to end up the talk. So the pertinent venous anatomy. This procedure has really forced us to relook at the veins of the upper extremity. And in the past, we may not have thought about the deep veins and a perforated vein. But when doing percutaneous procedures, you really have to work with Mother Nature and the anatomy that you dealt with. And for creation of an AV fistula, you want the A and the V really close to each other so that the percutaneous devices can do what they're supposed to do. Now, one location where the two structures come close together is the artery, where the ulnar artery or the radial artery have the concomitant veins running with them. So that's a really easy target to kind of use for creation or communication and joining the artery and the vein. And when you overlay the superficial veins on top of that, you see that the perforated vein now connects the deep system to the superficial system. So this is the whole anatomy that really is critical to fistula creation percutaneously, where the perforated vein is a linchpin taking the blood from whatever anastomosis is made and to kind of arterialize these superficial veins here. This is the cephalic vein and the basilic vein. So there's two kind of locations where the artery and the vein really come intimately close together. I mentioned the deep veins to the artery, and also the perforated vein, as it wraps around the radial artery, really comes in close contact with it. And this is where the two systems come into play. The ellipsis targets the radial artery and the perforated vein relationship, and the wavelength device targets the deep veins with the artery. So we'll talk about the wavelength device first. The original device was a 6-French system. And as you saw in the diagram before, it's a 2-catheter system. The idea is that you put a catheter in the artery and another one in the vein, and the catheters have magnets in them, as you can see radiographically here. And the magnets, when properly aligned, really bring the two catheters together, coap the wall of the artery and the vein. And then there's the kind of the action part of it, which is the electrode here, that you flick the switch and the machine does this thing. And then essentially it's like a controlled trauma. It'll cut through from the vein into the artery, and then that creates the communication, and the flow kind of goes from the artery to the vein. The whole concept came actually from observing that in patients that had traumatic fistulas from a stab wound, those fistulas are really tricky to kind of shut down. And so in a sense, this is like a controlled stab injury between the two structures. And then the second generation came out where they kind of downsized it to a 4-French system. And again, there's advantages to having a smaller system. But in addition, they made sure that the magnetic coaptation mechanism was much more improved and much more robust. And also the RF energy release was 0.7 seconds versus the 2 seconds for the original. So here's what it looks like, the 4-French system. You can't appreciate it really in the diagrams, but it's more squared off. And the important thing is the orientation markers. You have 2 circles over here. And when everything is lined up nicely, the circles on radiographs or fluoroscopy are nice and crisp. And then you know that everything is sitting nice and the way it should be. And radiographically, you can see the electrode lined up against the footstop of the arterial catheter. And at this arrangement, you can kind of hit the button and the connection is created. When things don't line up, although they look like they might be, you can see that the circle here is not as crisp. The magnets are not properly lined up, and the system tends to push itself apart. So again, mentioned that the wavelength creates connection from the deep veins and the artery. This can happen both on the radial side or the ulnar side. Here's just a quick schematic to kind of show you the system at play. So 2 catheters, and this is a generator box that ultimately imparts the energy. And this is the venous axis and the arterial axis. In this instance, it's the brachial artery. And the 2 catheters come advanced close to each other. And once everything's lined up and you're happy with the positioning, ultimately the button is pushed. And this shows there's a little blinking light, but in real life, there's a lot of energy imparted and activates the neuromuscular system, and there's actually sometimes violent contraction that happens of the upper extremity. But ultimately end up with this arterialized flow of the venous system. So here's a case example. In this instance, you can see 2 catheters, one coming from below, which is the arterial axis. And in this instance is the ulnar artery, and then the other axis is on the venous side coming from above. And this, again, kind of anti-parallel arrangement is just because the two systems are going opposite to each other. Start with an arteriogram to just look at the anatomy and kind of pick the best spot for where the arterial connection might be. In this instance, just beyond this little side branch here, you would aim for something in here. But it's also important to do a venogram to really see what's the location that's going to fill the perforator that as it exits up and into the superficial veins. And when those, you kind of try and marry the two locations, and once you've picked your spot, devices go in as showed in the animation. You arrange them so that they can maximal opposition, and everything looks good. You hit the button, and then you get the fistula. And this is what the fistula fluoroscopy image looks like. This star kind of shows where the actual connection is between the artery and the vein. And you can see that ideally you want all the flow to go up the perforator vein, which is the dotted blue arrow, and out into the superficial venous system, the cephalic vein on this side and the basilic vein on the medial side. But you also see the deep veins are pacified, which is not surprising because it is a connection in the deeper vein level. And you can see the ulnar veins appear and the brachial veins filling up with contrast. The red arrow just shows the direction of the arterial flow. So this filling of the deep veins is a potential issue that may come into play down the line. And in fact, in the earliest trials, they recommended coiling off the deep veins to kind of promote more flow into the superficial system. Just another example to kind of get your eye into what these fistulas look like. Here's a connection and the perforator vein filling up the cephalic and the basilic veins. One more example, perforator coming up into the superficial system at the cubital fossa, and this is just the artery pacifying with the contrast. So I mentioned the energy that can cause violent contraction, and here's just another component of the system. It's an arm board that was developed specifically to kind of really fixate the arm. It's laid on the bed before putting the patient on it, and has these kind of complex strap mechanisms, but it ultimately really stops the movement and the flexion. And you can imagine magnets are not really strong, and if any movement happens and the two catheters misalign, as the electrode comes out, it can really cause some damage to the arteries that was not intended. We've gone through this, sites of location and the anti-parallel and parallel options available. And these are what the things look like. So a lot of studies, a lot of data that was done, and the 6 French system data, I'll kind of just summarize as high technical success. They observed high maturation rates and also patency rates that were kind of acceptable. The 4 French system, again, did a similar pilot study in which high procedural success rates, so they were able to create the connection. Maturation rates at 3 months was also very high, and they noticed a high primary patency rates in their follow-up period of 6 months. In the NEAT trial, they noticed that the fistulas were usable, and also some of them, when needed, were able to offer functional fistula access for the patients that are needing dialysis treatments. The EASE trial, which is the 4 French system trial, a similar kind of outcomes. I'm just kind of going through stuff in the interest of time. But the 6-month patency, again, very healthy and respectable. The physiologic suitability, which means it met ultrasound criteria of fistula maturation, was very high. And also 74% of patients that needed dialysis were able to have these fistulas cannulated and used for dialysis treatments. I'm going to skip through all this, but just to kind of show another post-market study. The biggest issue with this, well, not issue, but the adjunctive procedure was coiling of the deep veins that was needed to kind of promote the flow into the superficial system, which is something not typically, we don't deal with coiling veins when we're dealing with fistulas in a normal arena. There's more to come. There's a new kind of trial that we just kind of started recently. But so that's the first device, which is the wavelength device. And I'll move on now to the ellipsis system, which is a little different. Again, as I mentioned earlier, this is targeting the radial artery and the perforator vein connection, or the approximation, and going to form a connection between the two structures at that point. Just a little cartoon animation to show how the device or the procedure works. It's a single puncture system as opposed to the wavelength. You come down the perforator vein, and at the crossover point, the needle is pushed into the artery. Then Seldinger technique, which kind of common to all procedures that we do. Wire goes in, needle comes out, the sheath goes in. And then once the sheath's in place, through the vein into the artery, delivery device, which is the ellipsis system. And note the gap here, which we'll kind of get to in a moment, but that is the kind of action zone and kind of coaps the two walls And once you're in a good position, you got good apposition, the foot plates come together, and then the thermal energy creates the anastomosis, or the connection. And here it is. So we saw what that looks like. Here's another drawing of it, and it's an over-the-wire system, just to kind of make that point. And here's just some ultrasound of a real case. This is the perforated vein wrapping around the radial artery. And then in long axis view, line up the perforated vein, and needle comes in right over the radial artery. And here's the puncture. It's really critical to get everything lined up so that you kind of make a one stick kind of procedure. And this is basically the whole case. From here, it's a Seldinger technique. We put the wire in. Then the sheath goes in. I'll kind of just fly through this a bit to get to the end. And this is the sheath coming back, and now you can see the device with the acorn, or the leading piece of it, within the artery. And then final step is to kind of pull the system back, get good apposition of the arterial wall. And once you kind of secure that, then you can push the button here on the device that coaps the 2 foot plates. And at the end, you kind of have a fistula created where you can see the turbulent flow of the vein. And that's what it looks like. It's an elliptical connection, and hence the name of the ellipsis system. So the pilot study done for this device, 26 patients. They again looked to see if there was a way to create a connection that was safe, and also the fistula ultimately, whether it was able to be used for dialysis. And they kind of proved all those points, all the boxes were checked. And interestingly, procedure times are real quick. And the maturation for these fistulas needed an adjunctive procedure 87% of the times. They moved on to the pivotal study, a much larger cohort. Again, the endpoints were the same. Was a connection able to create a fistula that would stay patent and offer use for dialysis treatments? And the first year data is as follows, kind of similar to the pilot study, where high rate of technical success, patency was high at 12 months, fistulas were able to be used when needed for 2 needle cannulation treatments. But look at this, the maturation of these required, nearly every case needed an adjunctive procedure for maturation. And in particular, it was balloon dilation that kind of really stood out over here. And most of these cases needed balloon dilation of the perforated vein to kind of augment the flow to get the veins to mature. And so much so that towards the end of the study, they've kind of incorporated the balloon dilation as part of the initial procedure itself. So just recently this year, they published the same cohort, followed them out for 5 years, and all the outcomes were reported. And again, 99% of the fistulas were mature. Those needing dialysis, high percentage actually got the fistulas to 2 needle cannulation and getting dialyzed to the access. Throughout the follow-up period, about 1/3 of them needed standard maintenance work, which includes balloon angioplasty for dysfunction or cannulation injury. And there was no device-related complications in the entire cohort, which is pretty impressive for this device. The French study, again, smaller cohort, but they kind of found the same outcomes, high success rate. Cannulation was high in terms of getting 2 needles in there. But note again that the adjunctive procedure in the requirements were very high, with balloon dilation standing out in this cohort as well. This is what they look like. You get a nice arteriocephalic vein and a basilic vein, and this happened to be the same patient. So you kind of end up with multiple veins that potentially can mature and become fistulized, which is a plus and a minus, because for good or for bad, these connections arterialize the entire venous system. And the implications of that are kind of to be determined down the line. And the other procedure or other concept to think about is you may need to do some more work on the deeper veins, in particular coil the deep system of veins, which in itself may be a plus or a minus. The adjuncting procedure talk about, a lot of this standard surgical things done for usual fistulas apply here, like transpositions. The standard catheter-based therapy is also applicable here with PT and thrombectomy, but in particular, there's going to be a lot of flow diverting procedures needed like banding and coiling. And I guess I'm out of time. But I got through most of the slides. I hope I give you a kind of overall view of what these devices are all about and what they can do. Thank you.